The Society of Actuaries has recently released a new research report entitled Dementia, Neurology Deserts, and Long-Term Care Insurance Claims Experience in the United States. How does a limited supply of neurology specialists correlate with claims experience data? The paper is a great analysis into how the supply of neurology specialists for diagnosis and care of Alzheimer's disease and the related dementias, how they relate to historical long-term care insurance cognitive claims. And what's this relationship between the geographic distribution of where neurology specialists practice and long-term cognitive claims incidents? And as we often do, we first want to look at some of the data that are being studied to research these types of questions. I know there was a lot of key data, key measurements used for assessing the impact of the supply of neurology against long-term care claims. So maybe we can jump into that. What types of measurements were used in this report?
So in terms of this report, what we ended up using was population health data from the Alzheimer's Association, along with claims experience data on the long-term care side, along with predictive analytics, which made this study pretty unique.
On the long-term care insurance side, we looked at historical long-term care insurance claims and hundreds of thousands of claims that we have in a collection of minimum long-term care guidelines data. And these claims we were able to split into claims due to cognitive causes and claims due to non-cognitive causes. So we brought those historical long-term care insurance claims to bear on this report, Dale.
And those types of scores and measurements certainly led to enable further analysis. So Robert, maybe I'll point to you. What are some of the key results you saw from the analysis in the report?
You know, we wanted to examine, were there places in the U.S. that had more cognitive-based long-term care incidence rates than we might otherwise expect? Or were there places where we would have fewer cognitive claim incidence rates? And so collecting this data across in a nationwide basis and looking at it by the states that the policyholders are in, we created kind of state-by-state scores, and mapped against a nationwide average, how much did the state of, Kentucky or Alabama or Maine, how much were their cognitive incidence rates compared with the nationwide average? Were they particularly higher or lower? And we were interested in trying to understand, is there a relationship between places where there might be much higher or much lower cognitive incidence rates for long-term care claims? Then there were the supply of neurologists. And Dr. Rao has worked on a paper that I'll let her describe on Neurology Deserts. And that's really kind of the marriage of the work that she's done with the supply of neurologists and the data that we collected, the actuarial data, the historical long-term care experience data, and kind of putting those two together. So, what we found is there's a small but modest correlation, a 10% correlation between the supply of neurologists and the cognitive incidence rate relativity for long-term care claims in our historical window.
Sure. And Robert, kind of with this data now being studied and the opportunities here, does it lead us to think of maybe some future areas of research to further explore with these types of results?
I think that the future of long-term care claims and morbidity analysis is really going to get into specific causes of claim. Long-term care needs are complex. There usually isn't just one single driver. But that said, people become frail due to aging for a number of reasons that Dr. Rao, I know, can elaborate more on. But we long-term care insurance actuaries have not historically gone into many of the details of why people have long-term care insurance claims. So the future work we can do, Dale, I think is going to be around really analyzing, the causes and the trends in the causes of why people have, long-term care needs, either receiving care in the home or getting care in a facility.
And Dr. Rao, let me bring you in. I mean, Robert's pointing to a lot of good information that you helped study here. You've done quite a bit of work and research in the neurology field, in particular Alzheimer's and neurodegenerative disorders. I guess from your point of view, what do you consider unique about this study, and in what ways would you call it kind of multidisciplinary across different practice areas?
Sure. This is a really fun project to work on with Robert and the Milliman team. So as Robert mentioned, long-term care insurance, around half of the claims with some carriers is due to cognitive conditions. And the study was unique because we, collaborated together where we could bring in long-term care insurance data with population health data and also data from the American Academy of Neurology to understand specialist need. And one thing that was unique was, we realized that these markets are often siloed. Insurance actuaries and healthcare providers often don't really talk to one another, yet they have so much to learn from one another. As healthcare providers, they're often the ones that are treating the medical morbidity prior to actually the claim being filed, and sometimes even continuing to treat the medical morbidity as the person is on claim. However, if you go to any healthcare provider and you ask them, hey, what do you know about the long-term care insurance claims process? They're not going to know anything. And I think there's a lot of ways that we could collaborate together using new and innovative technologies, new ways to capture data, and also predict for future reserving purposes.
And to your point, I mean, the term neurology deserts is used in this report. So let me ask you, to you, what exactly does a neurology desert mean, and how would you assess it in this situation?
Sure. So really simply put, dementia neurology deserts is a ratio. So it's a ratio between the number of neurologists per 10,000 patients with Alzheimer's disease or related dementia. And we chose neurologists in particular because about 1 in 3 Medicare beneficiaries sees a neurologist in their lifetime. So either for stroke or Parkinson's, neuropathy, or dementia in this instance in their lifetime. And we noticed that we noticed that there are regional differences between the supply of neurologists and the future prediction of the patient population. So Wyoming was the biggest neurology desert. So you're probably wondering, what does that mean for someone who's living in Wyoming? So that could mean, hey, there's increased wait times, but also if people don't have access to neurologists. So let's say there's a Parkinson's patient who has hallucinations. Well, there's actually a drug to treat that. And usually it's neurologists that are prescribing this medication. So that patient, because they don't have access to a neurologist, may not get the right treatment and care. And then subsequently, what happens is the family caregiver may become overburdened by these hallucinations, these nightly agitation, and almost prematurely put this person into an assisted living facility or a nursing home. So, these deserts have both impact on the patient side, but also on the healthcare provider and the insurance side on who's paying out.
Yeah, it's a great observation. I mean, so often we as actuaries sometimes just think of access to healthcare as whether you have an insurance policy or not, or you're covered. But here, access is literally, the geographic distance, or can I get to a provider when I need to, given my condition. And I guess I'd want to dig in a little bit deeper. I mean, can you describe the prevalence and current underlying clinical aspects of dementia, and maybe even further, how does it impact other morbidities that are seen?
Sure. Maybe I'll start with the second question first.
Sure.
So let's just take a comorbid condition that's pretty common, which is diabetes. If I have a patient with diabetes plus dementia, they may not remember to take their insulin 3 times a day. Or if their family is giving them the insulin, they may be agitated or sundowning, and so they're not going to receive that extra dose. So what that means is essentially they may end up with more ER visits, more healthcare hospital admissions, and overall healthcare utilization. So dementia essentially almost exacerbates or adds to the cost of the underlying comorbidity. And if we take a step back and we think about the prevalence of dementia, globally, it's about 50 million people have this disease. In the US alone, there's about 10 million. And by 2030, we're estimating about, this is going to be a $2 trillion disease. And when we look at the current costs of dementia, it's quite comparable to the 18th largest economy, which is, according to the World Bank, the GDP of Saudi Arabia. So, it's quite costly. And it's really a spectrum or a continuum of a disease. So there's pre-dementia, what we call mild cognitive impairment, and then there's mild, moderate, and severe disease. And just like cancer, dementia is an umbrella category. So there's many different types of dementia. The Alzheimer's disease is the most common. However, there's 15 other types. And why this is important clinically is because each type has its own treatment and care. And I'll touch on the new medication that's out for Alzheimer's disease. But from an actuarial perspective, it's also important to understand these subtypes because they have different mortality, different costs, and different utilization. So it's both it's a contextual need to understand these different types. And with the new launch of Biogen's aducanumab antibody, which is a monoclonal antibody against Alzheimer's disease, again, it's important to understand that people who may have vascular dementia or Lewy body dementia may not be eligible for the drug. And this drug is quite controversial. The jury is still out in terms of, is this going to work? The drug really focuses on what we call the amyloid hypothesis, which is, hey, there's a lot of amyloid plaque that builds up in patients with Alzheimer's disease, and this drug really targets that. However, one thing to point out is the FDA is asking Biogen to do a phase 4 trial to really see how does it really impact clinically, even though, on imaging, it improves amyloid, does that actually make a clinical difference on a person's day-to-day activities? And one last thing I'll mention is there are going to be administrative hurdles and probably longer than normal wait times for patients. So going back to these neurology deserts, keeping in mind, how are these patients going to access this new drug, right? And not only that, patients will have to get, imaging, they'll have to sometimes, in some cases, even get genetic testing to qualify for this drug. So the jury's still out and, it's a wait and see game.
One thing that I really want to highlight that Dr. Rao has brought up, and Dr. Rao, you did a great job of this. If you'll remember at the second long-term care medical symposium that the Society of Actuaries sponsored, we were really happy to have you and others there. These are some of the external factors, Dale, that I don't know that a lot of actuaries can really do a great job of planning for. It's very speculative, right? So in our actuarial models and our morbidity assumptions, we look at historical experience and we try to make the best guess at where long-term care incidents, mortality for disabled lives, all of these things may play out policyholder behavior, but the presence of a blockbuster Alzheimer's drug is not in our past data. And from what Dr. Rao says, this may not be the one that we're the industry could be waiting for, but to have a panel of experts, like Dr. Rao and others, sit around and provide some of that environmental input. What should we be considering? I think those are the sorts of topics, the kind of environmental inputs that we really need to pay attention to as long-term care actuaries. So that's part of what we wanted to highlight with this paper and the research we're doing, and I hope that a lot more research kind of plays into in the future.
Yeah, Robert, completely agree. I mean, today's health actuary, even today's life or pension actuary, kind of keeping one eye on what's going on and what recent historical trends on, but you need to have one eye to the horizon as well to figure out what medical technologies, what future healthcare costs and utilization will look like. Just a really important part of being that well-rounded actuary who's considering all the different scenarios that could play out. And perhaps we'll look back at this event a few years from now and say, hey, this was the starting point of trends. And for population mortality, Alzheimer's dementia is certainly one of the growing causes of death in the last 10 or 15 years. So, really we'll be interested to see how this all plays out. Well, Robert, Dr. Rao, I want to say many, many thanks for stopping by to discuss this really, really important intersection of the medical and insurance practice areas kind of coming together in this recent research report on Dementia, Neurology Deserts, and Long-Term Claims Experience. Thanks for joining us on this today.